Hey everyone, welcome back to Nurse Crit. My name is Chasen. I'm an acute care nurse practitioner. Let me just say, if you work with cardiac surgery patients, you know how dreadful cardiac tamponade can be. This is a medical emergency that can take out your patient right before your eyes. Let's review this scary condition so you don't miss it when it's happening to a patient right in front of you. In this video, we will go over the pathophysiology of cardiac tamponade, its risk factors, the clinical signs and symptoms, which diagnostic tests are used, and the treatment of tamponade. What is pericardial or cardiac tamponade? It's actually not too complicated. You have your four-chamber heart encased in a fibrous pericardial sac that holds the heart in place. So that the heart muscle doesn't stick to the inner surface of the pericardial sac, there is normally a small amount of fluid between the heart and the pericardium, around 20 to 50 mLs, that acts as a lubricant. Cardiac tamponade is a clinical syndrome that occurs when an excess amount of fluid accumulates in that pericardial space, which prevents the heart chambers from fully expanding during diastole. If the ventricles can't expand, they can't fill with blood, and that leads to hemodynamic compromise. If it's severe enough, it can lead to cardiovascular collapse and death. If you recall your different shock states, this is a form of obstructive shock, as the pericardial fluid accumulation causes an extrinsic physical obstruction to cardiac filling. When fluid accumulates around the heart, it is known as a pericardial effusion. It can be serous fluid or sometimes frank blood. When it's confirmed to be blood rather than serous fluid, it can more specifically be called a hemopericardium. A pericardial effusion does not always result in frank tamponade. It depends on the amount of fluid and the rate at which the fluid accumulates. A rapid accumulation of 50 extra milliliters can cause tamponade, whereas a gradual 500 milliliter accumulation over several weeks may actually not cause tamponade at all. It just depends on whether the excess fluid puts pressure inward and compresses the heart, or it gently puts pressure outward to stretch the pericardium. There is actually a long list of causes of a pericardial effusion and tamponade. Malignancy is the most common cause of tamponade. Cancer patients, unfortunately, experience a lot of third spacing around the heart, lungs, and into the abdomen. Other etiologies of tamponade include uremia, pericarditis, infectious diseases, anticoagulation, and connective tissue diseases. You can probably imagine any physical trauma to the chest, including iatrogenic trauma from open heart surgery, can cause effusions and tamponade. Type A aortic dissections can also bleed into the pericardial space. So those of you who work in CVICU and care for cardiac surgery or aortic dissection patients, you must always be on the lookout for possible tamponade. This is a disease that needs to always be on your radar. So what does cardiac tamponade look like in practice? The nice thing about tamponade in cardiac surgery patients is that we have a lot of monitoring that can give us a heads up. We have the ECG monitor, arterial line, Swan-Ganz catheter, and at a lot of places, an intensivist who knows how to use ultrasound. In patients with tamponade, we know that the heart is surrounded by extra fluid, preventing it from expanding, but it also can cause the heart to sort of float around loosely in the pericardium. One of the possible indicators of tamponade is on the ECG. If the heart is physically flopping around, you may see something known as electrical alternans. You may see the size of the QRS complex alternating between high and low voltage. This is not specific to tamponade alone, but should raise your suspicion. Similarly, if you have an arterial line, you may see an oscillating arterial waveform. This fluctuating change in pressure occurs with respirations and is known as pulsus paradoxus. This can be subtle, so make sure you are observing your A-line closely. In terms of blood pressure readings, tamponade disrupts the heart's ability to eject blood, so each heartbeat only yields a small amount of output. This can be noted by a narrow pulse pressure. Pulse pressure is the difference between the systolic and diastolic pressure and is normally about 40 to 60 millimeters of mercury. If you see a BP reading of 90/70, that's a low or narrow pulse pressure of only 20 points and may be concerning for tamponade. Lastly, if you have a Swan-Ganz or pulmonary artery catheter, you may observe what is known as equalization of pressures. When the extrinsic fluid is compressing the heart, it transmits that pressure throughout all the chambers. You will likely see the CVP and pulmonary artery diastolic pressure nearly equal in value. This combined with a drop in cardiac output and index is very likely tamponade in progress. Of course, all of this hemodynamic monitoring is awesome when you have it, but since the most common cause of tamponade is malignancy, more often than not, you won't have all these helpful numbers. You'll have to rely on history and physical exam findings. Clinically, patients in tamponade will present with tachycardia, dyspnea, and or tachypnea, as well as decreased urine output, confusion, and cold, clammy extremities. Those last three signs are highly indicative of a shock state in which there is inadequate perfusion to the organs and body. If you are taking any kind of board exam, you will invariably be expected to know Beck's triad as an indicator of cardiac tamponade. Beck's triad is the physical findings of hypotension, jugular venous distension, and muffled heart sounds. Despite this being a classic teaching, studies have found it to not be very sensitive nor specific for tamponade. This was first described over 90 years ago, so it's somewhat outdated in its utility when we have tools like point-of-care ultrasound all around us now. Speaking of ultrasound, echocardiography is widely considered the gold standard for diagnosing pericardial effusions and cardiac tamponade. The echo is a rapid modality that can be done at the bedside to evaluate the atria and ventricles for collapse and the severity of fluid that is surrounding the heart. CT scans can be used to evaluate for pericardial effusion, but it's a static image that can't evaluate cardiac output or estimate intracardiac pressures. Even if you note an effusion on CT, you still really need an echo to evaluate the severity of the tamponade and for visual guidance in draining the effusion. The least helpful imaging modality is the conventional chest X-ray. This is basically a screening test. You may note a wide mediastinum, which may indicate a possible pericardial effusion, but it cannot rule in or rule out tamponade alone. If you have clinical symptoms of tamponade and a big heart on X-ray, you should just quickly move on to an echocardiogram. Moving on to the treatment of cardiac tamponade, the definitive way to reverse tamponade is to drain the effusion from around the heart. This is generally through a procedure called a pericardiocentesis. Under ultrasound guidance, this procedure involves inserting a needle through the chest wall into the pericardium and stopping before you hit the heart. From there, the physician can aspirate or suck out all the problematic fluid or blood to restore cardiac function. Oftentimes, a small drainage catheter is left in place to continue draining fluid for 1 to 2 more days before it's removed. In the setting of post-cardiac surgery, if a patient is in tamponade, this most often requires a trip back to the OR. Although patients always have a chest tube within the mediastinal space, sometimes these tubes can get clotted off. Or sometimes fluid accumulates faster than the chest tube is draining, leading to tamponade. If you do care for cardiac surgery patients, remember that you never want zero output from a chest tube. We always like a little bit of drainage to let us know the tube is still working. Oftentimes, getting the patient to the cath lab or OR can take some time. To temporarily support a patient in tamponade, you most often want to give volume or blood products to try and fill up those squashed ventricles. You may also require vasopressors to support the blood pressure. Inotropes will be of little help since this is not a condition of poor squeeze, but rather a problem with filling the heart. It should be noted that positive pressure ventilation should be avoided when possible because it may decrease venous return, which is the opposite of what we want. These medical interventions are not a substitute for emergency drainage. You must get cardiology or cardiothoracic surgery involved to save a patient in tamponade. It's a rapidly fatal condition, and it scares the hell out of me when it's happening to my patients. Remember that tamponade is one of the H's and T's in cardiac arrest. The only nice thing about cardiac tamponade is that although it's highly lethal, it's also quite easy to fix if identified and treated promptly. I hope you enjoyed this brief talk on cardiac tamponade. Before you go, I wanted to announce that I recently self-published a nursing pharmacology book on Amazon. It's a very simple, to-the-point book on the key concepts to remember for any drug class. If you're anything like me and don't like to read that much, this book is for you. This is how I taught myself pharmacology, and I thought it could potentially help many other nurses in their efforts to get good at pharmacology. The book is titled Nursing Pharmacology TLDR Version. In case you're my age or older, TLDR stands for Too Long Didn't Read, which is a common expression among younger generations who don't bother to read things if they're too long. The book is currently only available in ebook format, which I do think is superior anyways, but in case you are averse to ebooks, I am currently working on the paperback version. Since this is a self-published book, I am still trying to figure things out and overcome some of the speed bumps I've encountered along the way. Thanks for watching this video. Please like, comment, and subscribe, and also consider buying my new book if it interests you. I will include the link in the description below. Thank you for your support, and I look forward to making the next video.